I'm going to start by introducing the people in our team. As you see, we have a number of faculty involved in our lab, led and mentored by our own Professor Oman. Then we have people who are helping me run the lab, lab managers and postdocs, and an army of graduate and undergraduate students who are the people who do the job, and I take the credit for it. So I thank them all before I start talking about our work. So I'm going to start with the mission of the lab. We are a computational lab. What we do, we use computational techniques such as artificial intelligence, machine learning, signal processing, image processing for clinical applications. In majority of the applications, we create decision support tools that are used by clinicians for their decision making. So in order to better explain what I'm talking about, I'm going to cover a few example projects. As much as we have time, I will go and introduce as many projects as I can. So in each of these projects, you will see that we identify a challenge that is normally a challenge that is faced in not just one application, variety of applications. And we create algorithms to address those, but I will clarify the way that we apply these solutions in at least one example. So the first one is the fact that you know that machine learning or neural networks and things like that are heavily used for decision-making in medicine, not clinically, just creating like papers and things like that. And one reason that they're not truly used as a decision tool in many clinical settings is the fact they are not transparent. We have a box, a neural network that makes a decision, and nobody knows why they're making that decision. So asking a clinician to make a clinical decision based on a box, a mathematical formula that creates like something, let's say in triage, saying let that patient go and focus on that one, nobody's going to trust that. They want to know exactly why the decision is made. So lack of transparency is an issue. Another thing is that clinicians have a lot of intuitive knowledge about what is happening in the field, in each clinical decision making. So why not create machine learning techniques that are capable of essentially doing that, like using the information, approximate information from clinician, and improve the performance of the model. So the example that I want to show you is how we generate a system for decision making for treatment provided to heart failure. This is supported. This is a research supported by National Science Foundation. And I will tell you briefly what is the technology that we talked about. As you see up there, we have three buzzwords basically in there. One is neural network. Everybody knows, neural networks are probably the most commonly used type of artificial intelligence, but often they're known to be non-transparent. They don't provide any information. Beside that, you see fuzzy, and fuzzy logic is a technique to express approximate knowledge and share it with others, which is what we need if we want to have some level of transparency on the network, on the machine learning. And the last topic, which comes first, is tropical geometry, which is a fantastic new field of mathematics that talks about essentially changing the geometry of the world by changing the operations that we use in algebra. So what we did, we designed a system. As you can see, this system is nothing but a neural network. It's trained like a neural network, it's structured like a neural network. However, when we train that, we use tropical geometry to make the training in such a way to allow us, in the end, have fuzzy rules coming out of this network. So we train it as a neural network, but in the end, we have systems that are completely transparent in the decision making. I'm going to tell you, I'm not going to get into the details of obviously, but I'm going to tell you how they work for heart failure. As you know, if somebody is diagnosed with heart failure, typically there are two paths moving forward. One is the advanced therapy that they have to think about mechanical devices or even heart transplant. Or the other option is continuing with medication and observing the patient. So this is a very sensitive decision, whether they want to qualify the person for advanced therapy or just continue on medication. So if you want to create a system to create that, say class 1, recommend for advanced therapy, or class 0, continue doing medication, it's a sensitive decision making that you need a reason for that, right? So I'm not going to show you how we designed the technique. I'm going to show you first some results. These are the results that we get in our technique, this tropical geometry fuzzy neural network with the long name. It shows that AUC and AUCPR, all of them are comparable to any other techniques that normally we use in machine learning. So in terms of the AUC is on par with all of them. It's just notice that even standard deviation in AUC is less than the rest of them, which means it's a more robust technique. But the major difference is that now that you have the trained neural network, you can go and look at the rules that express what is happening in the neural network. It's not only trained all the weights, now it presents the reason that is the reasoning or the knowledge that is hidden in the neural network. It basically tells you that there are 6 rules in there, and these rules are actually very transparent. So for example, you say that if blood pressure is low and chloride is low, then the person should go to the advanced therapy. It's not only telling you what the neural network is explaining. More importantly, if the new patient shows up and you give the data from this new patient to the neural network, it not only makes a recommendation for you, it will tell you which rules are fired. It tells the reason why they recommend this person to go to advanced therapy or not. I'm going to add one more thing in here that we did not, we can start the network, this network that I showed you from essentially completely random numbers as neural network does, but we didn't do that. We interviewed clinicians, cardiologists, and asked them, what is the gestalt that you're using? What are the general knowledge that you're using? And we incorporated that directly, injected that to the weight, and we started from there. So we didn't waste any knowledge in the field because it's there. Why not using it? So that's one of the techniques that I wanted to talk about. The second general pain and challenge that we see in the field is systematic integration of the auxiliary information. In many decision-making systems, yes, you have like input-output, you have data and decisions, but there are a whole lot of external sort of, I would say, auxiliary information that are present. And the question that we're asking, is there a systematic way of integrating this auxiliary information in decision-making? The example that I'm going to talk about that shows one of the solutions that we have in there is drug repositioning and repurposing using some algebraic method that we got from basically deep into linear algebra. So let me explain the problem. Let's say you're a pharmaceutical, you have a number of drugs, compounds in your shelf, and you have some target that you want to address in this particular disease. Let's say like there's a protein that you want to essentially address with a drug, right? You have from the knowledge, the prior knowledge of the field, you have some information that certain drug works with certain protein and certain drug works with another one and so on and so forth. So you have a very sparse matrix that shows the cases that have been reported, like the interaction between the drug and target. In reality, what you want to do in drug repositioning and repurposing, you want to explore the possible relationships, the interaction that exists in this matrix, and you don't know that. So you're given a very sparse version of the matrix, and your objective is to do what we call matrix completion. There are many techniques that act on matrix completion. You heard about the famous Netflix problem that is essentially the same as what we're talking about, matrix completion. But when it comes to the word of drug-target interaction and repositioning of the drugs, some pre-screening technique that uses only the data, machine learning approach was missing. So what we did, we made the observation first that this is the matrix that we want to complete. This is the one that is sparse, and we want to predict possible interaction between some drugs and some targets, proteins. But we have some auxiliary information. That auxiliary information, for instance, could be the similarity between the drugs. If you put similarity between the 3D structure of the drugs, this compound, that forms yet another matrix that's some auxiliary information that is normally essentially ignored. Same thing you have here, similarity between the targets, protein-protein interaction. We have databases of protein-protein interaction. Why not using that? So First thing that we did, we created some algebraic method that completes this matrix, but uses this information with the other two matrices. We call it coupled matrix completion. And I show you some of the results on that. But then we realized that in reality, this interaction between the drugs, for instance, can be measured or recorded based on different criteria. Maybe it's based on 3D structure, maybe it's based on toxicity and things like that. So in reality, what we have is a stack of matrices that show the interaction between the drugs. So you have a tensor of drug-drug interaction. Same thing here, when you look at the proteins, you're looking at proteins with respect to different interaction that they have in different pathways, different environment, and so on and so forth. So the question was, how do we extend our algorithm to go from coupled matrix completion to coupled tensor matrix completion, which we created the formulation for that. And I show you some results in here. This is coupled tensor matrix completion. This is coupled matrix completion performed on a large database that we extracted from drug bank. And these are all the competing techniques. If you look at the mean of AUC that you have in here, this is like much larger than the rest of them. I'm not surprised because we're using auxiliary information systematically. But you also look at, it's not at the cost of doing a lot of computation, because the runtime for us is really, really smaller than the rest of them. That I'm not surprised either, because we're using tensor reduction as opposed to neural network kind of approach. Another thing that I want to talk about is something that Brian and Ryan, they mentioned that this is the new center that with the strong support of Brian and Gil, we recently got established, equipped with the techniques that I mentioned in the previous case and so many other things that we developed over the years. We felt that it might be the time to address bigger problems in the industry, pharmaceutical industry, and try to create effective algorithms for data integration and data analysis. So this is essentially trying to address create bigger databases for the task and create new machine learning techniques for drug design and assessment. I don't know if this is the complete list, because like every day we have new partners coming. This is like a collaboration between academia and industry, and we have a lot of industry partners who want to get involved in it. The last thing that I'm going to say in the last 2 minutes of my talk is talking about some structure of the data, some of the techniques that we have developed in the lab. We recognize that in majority of the cases, we are ignoring the structure of the data in clinical data, in biological data, and we want to create tensor-based techniques to address this structure. This is as an example of that. If I show you this, and I tell you what is this object, I couldn't put it in one line, so I put it like, in 2 lines. If I ask you what this thing is, probably you have no idea, but I make it easy for you. This is letter A. That I flatten the data, but by putting the rows one after another. In other words, if you flatten the data, which is happening in majority of machine learning techniques, you kill the whole thing, right? Even humans cannot recognize that this is letter A by looking at this, but you can easily recognize this is letter A. So and this extends to this matrix is a tensor of 2 dimensions. Like you think about CT and MRI of 3 and so many applications that goes beyond the numbers that we normally work with. So how do we integrate all of this information? This is like a case that we've done with, physiologic signal for people who are recovering from different types of surgery, integrating all of the information from them in tensor format, reducing the tensors, integrating the tensor information with each other. And by doing that, we showed that we can significantly increase the performance of the technique. This is like predicting cardiac events, half an hour, 1 hour, 2 hours, 4 hours, and we've gone to 12 hours ahead of time. And we can predict that with like 90-something%, we can predict that. Last thing is, remember that this is one cohort. These are the people who had cardiac surgery. We wanted to see if we have a system like that, trained by some cohorts, like elective cardiac surgery, and go use it for another cohort. Cohort number 2 are the people who are undergoing vascular surgeries. And you see that the same technique, without any tuning on that data, trained entirely on cohort 1, can still work on this. So I want to, again, thank you all for your time. And I will have, if you have questions, I will answer later on.